Hi everyone and Assalamu alaikum. This is Dr. Chaman Khan and today we are going to discuss how to evaluate a patient with cystic breast lump. Well, the learning outcomes of this lecture will be, we will be discussing causes of cystic breast lesions. We will be discussing different investigations for cystic breast lesions. And we also will be knowing the different treatment options for these lesions. Let's get started with a scenario. A 25 years female presents with a history of pain and lump in her right breast for 2 months. On palpation, there is fluctuation within that lump. Axillary lymph nodes are not enlarged. How you will evaluate this patient? We will evaluate via triple assessment, which is a combination of history and clinical examination, certain imaging techniques. In this particular scenario, our choice will be ultrasonography and aspiration cytology, in which we will aspirate the cystic fluid and send it to the pathologist for examination of presence of malignant cells into it. So what is a breast cyst? Breast cyst is a sac that is filled with some fluid. They are common in women between 35 to 50 years of age. A cyst occurs when fluid accumulates due to obstruction of the terminal ducts, either due to fibrosis or because of intraductal epithelial proliferation. The symptoms of a breast cyst could be the change of size, shape, and soreness before or after menstruation, some pain or tenderness in the area, or it can be painless. It can also result in yellow-brown discharge from the nipple. A breast cyst rarely means cancer. However, it is important to investigate. A simple cyst on ultrasonography is seen as a well-defined, round or oval anechoic structure with a thin wall, while a complex cyst is seen as a cyst which has both the solid and cystic components, and it has got thick walls, and it can also be associated with septa that can be more than 0.5 millimeter thick. So this is the ultrasonography of how a breast cyst would look like. A simple breast cyst with completely black in color, while a complex breast cyst will have both the solid and the cystic component. In the picture, the black area, it shows the cystic component, and a grayish area tells about the solid component. If you do an MRI of the breast cyst, you can see a well-circumscribed, rounded, hyper-intense lesion within the breast. The treatment of breast cyst is ultrasound-guided aspiration. You can see how an ultrasound-guided aspiration is performed. The ultrasound probe is placed to localize the exact site of the breast cyst. And then a needle is introduced with a syringe and fluid is sucked out. This fluid can be sent to the histopathologist for cytology and other examinations. So how breast cysts they are managed? It depends about their consistency, whether this is solid or cystic. In the case of complete cystic lesions, they are totally aspirated and patient is re-examined in 4 to 6 weeks. The patient is re-examined for recurrence. If there is no recurrence, a routine follow-up is done. And if there is recurrence, you can have a re-aspiration for another time. And if there is a recurrence for the third time, then you can go for an excision biopsy. In the case of the complex cyst, the liquid portion is aspirated, and for the solid portion, you can go for a biopsy and manage the mass according to the histopathology report. Let's take another scenario. A 26 years lactating mother presents with sudden appearance of a lump in her left breast. The lump remained asymptomatic for a couple of days and now started pain within it. The overlying skin is also getting red now. What is the most probable diagnosis? Well, our diagnosis will be probably infected galactocele. What is a galactocele? It's a milk-filled cyst that are round and well circumscribed and mobile. They can appear up to 6 to 10 months even after breastfeeding has been stopped. It is thought to be due to inspissated milk within ducts. The treatment of galactocele is that it can be aspirated, and surgery is reserved for those cases who become infected. So again, the treatment of galactocele is ultrasound-guided aspiration. And you can see this syringe that is filled with the milk. You will also have to see whether the discharge is caused by the drugs or not. If it is because of certain side effect of the drugs, the discharge may disappear after stopping that drug. If the galactorrhea is caused by a pituitary gland tumor, it can be treated with bromocriptine, which stops production of prolactin. In the case of the macroadenomas of the pituitary glands, you also need surgery. On ultrasonography, an infected galactocele looks like a complex cystic mass. You can see it is not very much well defined, and it has both solid and cystic components. Let's take another scenario. A 35 years lactating mother presents with history of engorgement of her right breast for 5 days. The breast skin is red, hot, and tender. Axillary lymph nodes are also enlarged. Your diagnosis will be breast abscess. It occurs because of some bacterial infection that can cause pus to collect in a localized area just below the skin. When a pocket of this pus forms inside the breast, it is known as the breast abscess. It is a very painful condition and requires urgent medical treatment to avoid complications. Well, the breast abscess can be because of lactation. It can occur in lactation period. We call it a lactating infection. It usually occurs within first 6 weeks of breastfeeding, and it presents as pain, swelling, tenderness, or a cracked nipple or skin abrasion. Staph aureus is the most common organism, but Staph epidermidis and streptococci, they are also can be present. The other type can be non-lactating. This variety is less common, and there is most of the times underlying associated conditions like diabetes, rheumatoid arthritis, or patient can be having steroids. This is how a breast abscess is treated. The small breast abscess can be aspirated, while the larger ones may need incision and drainage. You will also have to give analgesics and antibiotics. Breastfeeding may be continued in the uninvolved side. The infected breast is mechanically pumped every 2 hours. Once cellulitis has resolved, breastfeeding from the involved side may be resumed. If breast abscess occurs as a result of the infected Galactocele, at times you can see milk coming through that area. So in that case, you will have to provide milk suppression by bromocriptine. Patient will have to stop the breastfeeding, otherwise it will lead to formation of milk fistula. This is another scenario. A thin, lean young lady presents with history of multiple lumps appearing at different sides of her right breast for 1 year. These lumps then rupture and lead to multiple discharging sinuses which do not heal without antibiotics. There is also a history of weight loss and low-grade fever. What is the most probable diagnosis? And how you will manage this patient? The most probable diagnosis is tuberculosis of the breast. This is a rare disease, but it is not that rare in our part of the region. It is usually associated with pulmonary tuberculosis or cervical tuberculosis. It presents as either multiple cold abscesses or sinuses or nodules. Axillary lymph nodes are enlarged and matted. Diagnosis is done by biopsy, in which characteristically granuloma formation can be seen. Treatment is with anti-tuberculous drugs. In resistant cases, at times, you may end up with mastectomy. So these are the first-line anti-tuberculosis drugs. And the names are isoniazid, rifampicin, pyrazinamide, ethambutol, and at times streptomycin. We can also have some second-line drugs, and this is the list of the second-line drugs if you are not able to give first-line drugs because of any reason. This is the dosage of anti-tuberculosis drugs. Isoniazid is given at a dose of 10 milligrams per kg body weight. Rifampicin as a dose of 10 to 12 milligram per kg. Ethambutol at 20 to 25 milligrams per kg. Pyrazinamide at 30 to 35 milligrams per kg. And streptomycin at 50 milligrams per kg. The ATT regime includes the initial intensive phase of 2 months in which you give isoniazid, rifampicin, pyrazinamide, and ethambutol. The 4 drugs are given for 2 months. After that, in the continuation phase, the 2 drugs, they are given for 4 or 6 months. Isoniazid or rifampicin for 4 months, or isoniazid or ethambutol for 6 months. And then it is stopped. The different adverse effects of antituberculosis drugs include isoniazid and rifampicin. They are hepatotoxic. Pyrazinamide, it causes hyperuricemia or gout. Ethambutol can cause optic neuritis. And streptomycin is associated with vestibular dysfunction and nephrotoxicity. So the summary of today's presentation is the breast cysts can be simple or complex. Cystic breast disease lesions can be because of fibrocystic disease, galactocele, breast abscess, or tuberculosis. Evaluation is done via triple assessment. Simple breast cyst can be aspirated, while complex cyst may need excision. Treatment of the underlying cause is done. That's all for today. I hope you liked the video. Thank you very much. See you next time.